Mike Gibson, David Kandzari, coming to you live from ACC 2024, and we're talking about alcohol-mediated renal denervation, kind of a new technique from what I can see, and its effect on blood pressure when you're already on antihypertensive medicines. Dave, talk to us a little bit about what you did.
Thank you. Thank you, Mike. Thanks for having me as part of this program. Recognizing the benefits of more intensive blood pressure lowering, acknowledging very poor levels of hypertension control, not only in this country, but abroad for what is the leading modifiable cause of death, hypertension, and then also with increasing awareness of non-adherence to lifestyle interventions and medications. This has altogether opened the opportunity for alternative therapies for the treatment of uncontrolled hypertension. Renal denervation therapy, recently approved by FDA with two technologies of intravascular ultrasound and radiofrequency energy delivery, have motivated the expansion in the space of additional methods of achieving renal denervation, and specifically with alcohol-mediated renal denervation using this particular technology. And specifically, with this technology, a catheter is inserted into the renal artery of appropriate size, and through this catheter, three plastic guiding tubes are extended opposed at 120 degrees. And through these guiding tubes are extended three 8/1000 inch diameter needles that extend into the perivascular space, so therefore outside the renal artery, that permits delivery of 0.6 milliliters of dehydrated alcohol. And the alcohol, because of its diffusion characteristics, it's limited in its scope, but it's quite capable of achieving a very confluent circumferential arc of ablation with a single treatment. And so for a procedure, renal denervation, that still to date across all technologies has no procedural biomarker of completeness of denervation, at least in concept, this is a one-stop shop, so to speak, for achieving a very, with high degree of certainty, a very confluent arc of ablation with a single treatment in each renal artery and or accessory renal arteries, if permissible.
And David, is that the differentiator here, the confluence of the denervation? What are some of the differentiators of this kind of technology?
Great question. So number one is that in comparison to radiofrequency energy with the Medtronic Spiral program, where we're placing multiple catheter placements with renal denervation and application of radiofrequency energy, and even with that technology going into the distal branch vessels, and then alternatively with the ReCore intravascular ultrasound technology, where there's one or two insertions into the main renal artery alone, not into the distal branch vessels, but we're applying a heat energy through ultrasound and mediating a confluent arc. This is a one single treatment in the renal artery that, again, is able to, with the diffusion characteristics of alcohol, achieve this circumferential, more confluent arc of ablation. So perhaps it would, at least in theory, remove the unpredictability of the procedure. When, again, we don't have a biomarker of completeness of denervation, it also would, at least for the operator and for the patient, facilitate procedural time and perhaps may be associated with less discomfort for the procedure as well.
Got it. And what do you find?
So in this trial, we enrolled 1,414 patients at 99 centers within 9 countries, of whom 301 patients fulfilled the enrollment criteria. And specifically, this was a trial unlike many other prior renal denervation programs that included both uncontrolled and, so to speak, treatment-resistant hypertension patients. That is, these were patients who had an office systolic blood pressure between 150 and 180, and a diastolic blood pressure of at least 90 millimeters mercury, a 24-hour ambulatory systolic blood pressure of 135 to 170, but they were prescribed 2 to 5 antihypertensive medications. So a bit broader than what we've seen in previous programs and previous trials. And these 301 randomized patients were evenly randomized to renal denervation versus sham control to examine at 3-month follow-up the between group difference in ambulatory 24-hour systolic blood pressure. And in this study, we observed an overall difference between the two groups of 3.2 millimeters mercury in that favored renal denervation with a p-value of 0.049. And specifically in this trial, there was a large reduction, an absolute reduction in ambulatory blood pressure with renal denervation, a 10 millimeter reduction in blood pressure, systolic blood pressure over 24 hours with renal denervation, but also an unexpectedly large reduction in the sham control group of 6.8 millimeters, translating to this 3.2 millimeter difference. We saw a similar reduction in office systolic blood pressure, again, because of a large reduction in the sham control group of 3 millimeters between the two groups. This did not achieve statistical significance for office systolic blood pressure. And moreover, we observed no significant differences in ambulatory blood pressure between the two groups, although, again, numerically lower, favoring renal denervation. A couple other notable findings of this trial, too, were that the point estimates generally favored renal denervation across all pre-specified subgroups. But we also tested adherence for prescription adherence by both blood and urine toxicology studies. And interestingly, although there were no significant differences between the sham group and the renal denervation group at baseline and at 3-month follow-up, non-adherence, either partial or complete non-adherence, was quite high in this trial. It approached nearly 60% at baseline, and it was about 50% at 3-month follow-up. And so how this non-adherence may have challenged or confounded the results remains uncertain.
Wow. Well, this is why we do sham-controlled trials, right? So what's the next step? What do you plan on pursuing?
So importantly, the study has limitations not only related to the adherence issues that we've described, but also the follow-up is limited to 3 months. And as with other renal denervation programs, even dating us back to the Simplicity HTN-3 study, we've observed that as we follow these patients over a longer term, we see persistent reductions in the renal denervation patients, and we see an erosion of blood pressure control in the sham control patients. That's, of course, especially after unblinding, which in this case will occur as occurring at 6-month follow-up. And so right now, these findings are limited to 3 months. And so we'll have dedicated follow-up over a longer term to truly understand and inform whether this therapy is an effective method for the treatment of uncontrolled hypertension. I'd also add, too, that it proved to be a very safe procedure. We saw no major adverse event differences in outcomes between the two groups, which were very infrequent to begin with.
Great. Well done. Thanks, David. Thanks for presenting this to us, and thanks to all of you for joining us here live from ACC 2024.
Thank you, Michael.